Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson to the Amox Independent Committee. Warm welcome to all the respected dignitaries and faculty assembled for today's event. Today's theme is key issues in obstetrics and gynecology. We have three eminent stalwarts from all over the country who are gathered here today for the scientific proceedings to deliver some amazing talks. We look forward to hearing from them. But before we proceed with the scientific program, let me begin by offering my gratitude to our beloved President, Dr. Nandita Palshetkar. Next slide, please. Dr. Nandita Palshetkar is the current president of OBS. She is the immediate past president of OXI, also been a president of IAG and Royal Society in the past, vice president of SAR. We always look up to her for guidance and her blessings in all our academy. Thank you so much, ma'am, for always being there for us as a pillar of support and for guiding us throughout these difficulties. Next slide, please. I would also like to express my gratitude to Dr. Gutnaik, who is a distinguished academician, a fantastic vaginal surgeon, currently the Secretary of Commerce. We thank him for his support. Next slide, please. I'd also like to express my gratitude at this stage to the ICOG chairperson. Recently, Dr. Udait Anavala sir has taken over as the chairperson, and the secretary of ICOG, Dr. Ashok Kumar, is also the chairperson. We look for this. Next slide, please. We have four amazing stalwarts all over the country who are here today as chairpersons for today's program. First and foremost, it's my proud privilege to welcome Dr. Rajendra Singh Deshi sir. Sir is the Vice President of Commerce. He's also been a Vice President of OXI in the past when Dr. Nandita President. Same unparalleled record of winning 6 Best Paper Awards at the ICOG conferences, invited faculty to several national as well as international conferences. Thank you so much, sir, for being with us throughout the past 1 year while we've been conducting these conferences. Next slide, please. As I said just a couple of minutes ago, we are also proud to introduce Dr. Ashok Kumar sir. Sir is the Director Professor and Head at the Department of GYN, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Hospital in New Delhi. He's an MD from AIIMS New Delhi and a PhD from the Tokyo Women's Medical University, Tokyo. Secretary of ICOG for the tenure 2021. Also the editorial board member of Indian Journal of Medical Research, Archives of Gynecology and Obstetrics, known as a fantastic academician with over 120 indexed and 80 indexed publications. He's conducted several projects as the principal investigator, including for the ICMR as well as the university. We're really privileged to have sir with us. Next slide, please. It's also my privilege to welcome Dr. Anjana. Madam was the Vice President, say in 2017, the organizing chairperson for the National Proxy Conference, EOH, which was organized in 2017. She is the organizing secretary for SAVMA Conference in 2016, Vice President in charge at the North River Foxy in 2017. President of the Allahabad OBGYN Society 2013 to 16, and an honorary secretary of AOGS in the past. She is a recipient of the Foxy Smriti Mailan Award in 2013, and we look forward to seeing her very soon. Next slide, please. And last but not least, I would like to introduce my friend and colleague and co-chairperson. Next slide, please. Dr. Rajendra Nagarpatti. Sir is the current chairperson for the MOGS Midlife Management Committee. He's recently completed a very fantastic tenure as the chairperson for the Foxy Midlife Management Committee. And he's somebody who in Mira Bhayandar we look up to a lot, organizes so many events. Almost every weekend he has at least 2 or 3 different events, or he'll be driving to the suburbs and enjoying with friends. Nagarpatti sir also as the chairpersons. There's a slight change in the sequence of events for today's program. Dr. Priyampur Roy was supposed to be the first speaker. He's stuck in an emergency and will be joining about 10-15 minutes late. I would request Dr. Rajendra Singh Pardeshi sir to please introduce our first speaker, Dr. Varshale Madam. And she is well known to all of us as the zonal coordinator of AMOGS, but she is very recently been elected president-elect of the Nasik GYN Society. Over to Dr. Rajendra Singh Pardeshi sir to introduce Dr. Varshale, our first speaker.
Thank you, Dr. Pratik, for your kind introduction. Dr. Pratik is our enthusiastic, active, and energetic chairperson of AMOGS. Dr. Archana, just I wish to tell you all, these are pillars of AMOGS. Dr. Pratik, Dr. Rajendra Nagarkatti, and even Dr. Varshale. She is zonal coordinator, and these both are chairpersons, and they are doing really excellent work in AMOGS. Now to introduce Dr. Varshale. I think she doesn't need any introduction. Not only in AMOGS, but all over, she is known. She is graduate and postgraduate from PJ Medical College, Pune, past organizing secretary of NOGS 2016-17, vice president of AMOGS 2012, and vice president 2003, past secretary of IMA, past joint secretary of FOXI, then member of breast committee, adolescent committee, national speaker for guestosis, and published papers in international journal. And as Dr. Pratik told, now congratulations to Dr. Varshale for elected as president of NOGS, president-elect. Now I think Dr. Varsha is the right person to address us on fibroids. Over to Dr. Varsha.
Good afternoon, everyone. Am I audible?
Yes, you can. You can go ahead.
Good afternoon. Thank you, Dr. Pardeshi sir. Thank you, Pratik. I extend my gratitude and thanks to our President AMOGS, Dr. Nandita Palshetkar and Arun Naik as secretary. They have given me opportunity to talk on new medical management of uterine fibroid. As we have gone through this bad pandemic, is my slide visible?
No.
It's not going ahead.
Varsha, you just open your presentation.
Okay.
Then minimize it.
Okay.
And then go to share screen.
आता दिसतात slide sir?
नाही शेअर स्क्रीनला जाऊन त्याला डबल क्लिक करणार. तू डबल क्लिक नाही केलं. शेअर स्क्रीनवर जाऊन त्याला डबल क्लिक कर. हा आता होतंय हळूहळू होईल. येस याला व्ह्यू स्लाइड शो कर. झालं ना?
झालं.
Yes. Continue.
This COVID pandemic has taught us many things. Values of family, values of health. Of course, I treated almost 5,700 COVID patients in Sinnar RH. And I realized that I forgot almost all the gynec drugs. And since Dr. Pratik has given me opportunity to talk on some newer drug, I started reading. Last 8 days, I am reading this. And in this COVID pandemic, we realized that we started with some steroids, we started with some remdesivirs and whatnot. And then at the end, we realized that nothing is working. And we shifted to some Ayurvedic and herbal drugs. We started with some kadas, and somebody flew from Mumbai to Nasik to take that small white pellets and for prevention of COVID. I think we have to go for some Ayurvedic drugs, which today I am going to talk. Let us hope that I hope that this saying make you little stimulated. That it's difficult to say what is impossible. For the dream of yesterday, it is a hope of today, and the reality is tomorrow. Let us talk about medical management of uterine fibroid. As we all know, this disease, this is a tumor which comes in fertile age. The symptoms ranges from menorrhagia to pain. 20 to 30% of women in reproductive age have uterine fibroid. Most of them are asymptomatic, and nearly 15 to 25 million Indian women have fibroid, which ranges from 1 centimeter to 20. As per the FIGO, depending on the insertion of fibroid, percentage of fibroid into myometrium, the classification is there, but we should know that intramural fibroid contribute about 75%, submural fibroids 15%, subseral fibroid 10%. So symptomatology ranges from menorrhagia to infertility. Many of the women are asymptomatic, but dysmenorrhea is one of the symptoms. Then it comes to the urinary symptoms, and infertility may be one of the symptom as the patient may present to you, and she may have anemia. There are two major modalities of treatments. We all are aware of surgical and medical treatments. Hysterectomy was previously done for any fibroid. Then came the minimal invasive surgery like laparoscopy, and we started doing myomectomies. Umbilical artery embolization was one of the intervention modality which we started, but after some time it went off. Let us see what are the medical modalities. The current treatment options are selective progesterone receptor modulators. We have used combined hormonal contraceptive, LNG IUCD for those who have menorrhagia, oral progestins, androgens. We started with danazol and we have used it. GnRH agonist, we only had this GnRH previously. Non-steroidal anti-inflammatory NSAIDs and antifibrinolytic for the medical management. The future management includes asoprene-sil, elagolix, and relugolix. It is yet under trials. I am going to talk on one medical herbal option which is naturally available, Triptoridium wilfordi, which has EGCG as well as vitamin D along with it. There are limitations to medical surgical management options because patient may have surgical morbidity. They go into the risk of long-term complications, surgical complications, and there is complete loss of fertility after hysterectomy. After myomectomy, she may have recurrence and there is potential uterine rupture during pregnancy or delivery. Umbilical artery embolization, I have seen many patients who complain of pain, may have other complications as well as recurrence. Many patients land up into hysterectomies. Of course, embolization may lead to hypothetical potential of ovarian failures, or there may be abnormal placental development. We had a nice drug. We are using GnRH analog. GnRH is rapidly metabolized decapeptide, which is produced and released from anterior hypothalamic area, which reaches to anterior pituitary through portal system, which believed to bind to a specific receptor in anterior pituitary, stimulate the synthesis and secretion of LHFSH. Half-life is 2 to 4 minutes, and to increase the potency and duration of GnRH, analog with an agonist or antagonist properties have been synthesized and are available in the market for the clinical use. GnRH analog mimic the innate GnRH and desensitize the receptor, further inhibit LH and FSH. This gives 30 to 65% reduction in the size of the fibroid, and uterus can be achieved. It reduces the intraoperative blood loss if it is given preoperatively, and it decreases the hospital stay and help to convert some laparotomies into minimal invasive procedures. But there are chances of regrowth of fibroid of pre-treatment with GnRH. It may make surgical planes indistinct during myomectomies, as we have all experienced it. Preoperative depoluprolite 3.75 milligram after every 21 days for 3 months is only FDA approved GnRH analog. The second drug is selective progesterone receptor modulator, that is ulipristal acetate, which came into market very fast and we started using it very rampantly. Originally, it was used for medical termination of pregnancy as higher doses up to 30 milligram. It came in use following the discovery that progesterone plays as important role as estrogen plays in fibroid growth. The lower doses of reducing myoma size and managing the symptoms where it was 5 to 10 milligram. It has action on fibroid. It shows that it increases the apoptotic activity and anti-proliferative actions. It reduces the expression of TNF receptors, and it decreases the fibroid size and volume. It also acts on HPO axis as it decreases the levels of FSH and LH, which inhibits the ovulation. At endometrium, it shows anti-proliferative action, and it induces the menorrhagia, reduces the menorrhagia, inducing the amenorrhea in patients having bleeding. NSAIDs, some medical therapies has limitations. NSAIDs, we have less trials and less evidence to support. It has got GI side effects and gastric ulceration. Tranexamic acid, we have used it for menorrhagia and dysmenorrhea. It increases the size of myoma. GnRH agonist, we have seen that it gives hot flashes, vaginal dryness, as well as decreased libido. It increases the bone mass loss and increase the risk of osteoporosis. Use is limited up to 6 months. It is not safe and contraindicated in adolescents. It is painful injection, has low compliance with the patient, and it has risk of recurrence. And of course, it is an expensive drug. Danazol, long back we have used it, but it shows androgenic side effects like acne, hirsutism, and edema, and associated with liver toxicity. It has got effect on lipid metabolism and weight gain and musculoskeletal pain. Progestin, we have used it for menorrhagia and dysmenorrhea, gives breakthrough bleeding, and COCs also gives rise to breakthrough bleeding. It is not safe for long-term use. And for ulipristal acetate, the European Medical Agency has recommended revoking the marketing authorization of ulipristal acetate because of the risk to the liver injury. So patient is at risk, or measure to reduce the risk could not be identified. So it is recommended to revoke the marketing authority authorization of ulipristal acetate. So it is not in use. If you look at the pathophysiology of the fibroid, estrogen, progesterone bind to their receptors, and it increases the secretion of growth factors, leads to fibroid proliferation and growth of fibroid. Also, there are new pathologies has come in, which shows the catechol O-methyl transferase enzyme, which has highly expressed in patients of uterine fibroid compared with the normal myometrium, which leads to growth of the uterine fibroid. As well, the TGF factor beta 3 is elevated 3 to 5 folds in fibroid compared with myometrium, which causes overproduction, inducing collagen, fibronectin, and proteoglycans, which is a key regulator of cell growth and differentiation. Also causes leads to inflammation and apoptosis. Let us see what is the relation of vitamin D as well as obesity and family history of fibroids. This is the study which is published in Fertility and Studied in 2017, shows significant lower 25 hydroxy vitamin D in patients of uterine fibroid. Thus, the vitamin D may be a potential protective factor against the development of uterine fibroid, as well as there is increased TGF beta concentration associated with increased risk of uterine fibroids. So, to complete pathophysiology of uterine fibroid, estrogen, progesterone are the receptors expression, and aromatase enzyme levels increased, as well as COMT expression is increased in fibroid, as well as TGF beta expressions. So we need to take care of all these major etiological factors, and we need to find out some drug for that. So let us go to this preparation, which contain Triptorzium vilfordi, which is an ideal drug which take care of etiological factors of uterine fibroid. It acts on both progesterone as well as estrogen receptors. It hits the new target of fibroid, that is COMT and TGF beta 3, which is self and tolerated because it is natural. Triptorzium vilfordi 20 milligram has and it has got CG, which is 400 milligram green tea extract along with vitamin D3, which is 1000 international unit, and the main active constituent triptolide, which is a main ingredient. So this is a novel non-hormonal treatment for uterine fibroid. This is a trial which is done in China, which is used for clinical application of TW for treatment of some gynecological disease, which has proved the efficacy of new drug for the treatment of gynecological disease because it is more of anti-inflammatory, anti-tumor, anti-fertility, and immunoregulatory effect. What is its action? It inhibits the expression of estrogen progesterone receptor and the estrogen progesterone biological effect in fibroid tissue. It decreases the anti-apoptotic factor BCI2 and increase the apoptotic factor caspase-3. It inhibited aromatase enzyme, reversibly inhibit function of ovary and interrupt ovarian follicular development. So inhibit ovulation and induce menorrhagia. This everything will lead to decrease in the size of the fibroid and menstrual blood loss. It has been recommended by a NICE, National Institute of Healthcare Excellence. Compared with conventional medicine, TW may be beneficial effect on reducing the volume of fibroid. It has got strong antifibrotic agent, reduces TGF beta expression, reduces the expression of collagen type 1 and fibronectin, and decrease the extracellular matrix production, leads to anti-proliferative activity and reduces the expression of PCNA. So it acts, TW acts on estrogen progesterone receptor, GCG, which is a T extract, which decreases the COMP expression, and COMT expression, and vitamin D3, which reduces the TGF beta 3 expression, ultimately lead to decrease in the size of the fibroid. So benefit and clinical results of triptolgium: it decreases the menstrual blood loss by reduction of 188. This is the trial which has been done to study the TW effects on fibroid, which it has also increased the hemoglobin level by 2 gram percent, and decreases the fibroid volume from 27 to 68%. It has decreased the uterine volume from 80 to 60%. It has decreased in the progesterone level by 57% and decreased in the estrogen level by 41 to 48%. And it has also regularizes the menses after 1 to 3 months of stopping of therapy. This is also a pilot double-blind placebo-controlled trial done in 33 premenopausal women for myoma more than 2 centimeters. Green tea extract was given 400 milligram BD, and there was a control group of 17 women. The outcome was the mean change in the uterine volume. There was mean change in the fibroid specific symptoms and severity. There was mean change in fibroid specific health related quality of life. The quality of life score increased by 20 in GCG group, and against the placebo group it was 2. Significant decrease in the blood loss and increased hemoglobin. It was well tolerated. There was no adverse side effect, no abnormalities in liver function test. So to conclude, ECGC shows promise as a safe and effective therapeutic agent for women with symptoms of uterine fibroid. Such a simple, inexpensive, and orally administered therapy can improve the woman's health globally. There is a risk of less vitamin D deficiency and uterine fibroid. This was a trial done in 2018. The National Institute of Environment Health Sciences, the uterine fibroid study enrolled randomly selected 35 to 49-year-old women from 2096 to 99. Fibroid status was determined by ultrasound screening of perimenopausal patient. 10 nanogram per ml increase in 25 vitamin D, 20% lower adjusted odds of having uterine fibroid. So uterine fibroid express reduced level of vitamin D receptor. This might be the risk factor for fibroid pathogenesis. So vitamin D3 may have potential as an effective therapeutic agent for uterine fibroid treatment. This was again a trial for hypovitaminosis, and vitamin D supplementation was given about 50,000 international units of vitamin B3 once in a week per week for 8 weeks, followed by maintenance therapy of 200,000 international daily were given to 108 patients, and 12 months and volume increased significantly in the control group. So vitamin D3 has helped the women. Supplementation of vitamin D3 with 25 OH D3 restores the normal vitamin D serum level in women with small burden fibroid. In these women, vitamin D3 supplementation seemed to reduce the progression to the extensive disease, and thus the need of conventional surgical or medical treatment therapy was reduced. So vitamin D3 was indicated in symptomatic, as well as Cryptorhium wilfordi was indicated in patients with symptomatic management of uterine fibroid, or you can give it to preoperative management of uterine fibroid. It has the dosage schedule is a capsule twice a day minimum for 3 to 6 months, and therapy can be started from any day of the menstrual cycle. It reduces the size of the fibroid and the volume. It controls the anemia. You can buy time of the correction of anemia for the fibroid if the patient has menorrhagia. The menstruation resumes quickly. It suppresses the disease progression. It improves the health-related quality of life, and it is safe and well tolerated. This is the differentiation between hormonal and non-hormonal therapy. The hormonal therapy reports to have a liver injuries with ribitol acetate, while it is a non-hormonal is safe in for liver and kidney. It can be taken at any time of menstrual cycle, while hormonal it has to be taken on first and seventh day of menstrual cycle. So to conclude, we can definitely go for this hormonal and herbal preparation for the patient, those who are unfit for surgery, who are there for the correction of anemia. And to end my talk, I can say that a medicine cat has no time for a doubt. Put your energy into today and stop worrying about tomorrow. Thank you so much for your patient hearing. And I thank Dr. Pratik Verma for giving me opportunity. And thank you so much.
Thank you, Dr. Varsha. She has explained very nicely this topic. Basically, she has narrated all aspects of this drug, that is Integra wilfordi. Actually, it's a hormonal, and the effect is very nice. It's a really excellent molecule because it reduces fibroid size 27 to 30%, and it stops the bleeding and increase the quality of life. Also, hemoglobin percentage will increase, and there are no effects on other side. You can take it in the menstrual days also because it's a non-hormonal. So it's a nice presentation, Dr. Varsha. Thank you so much.
We'll go to the next speaker. Dr. Archana Verma is our next speaker. Is Dr. Nagarkatti there? Can I request Dr. Nagarkatti or Dr. Anjana Khanna ma'am please introduce our next speaker? No, ma'am, we can't hear you, Dr. Anjana Khanna ma'am, we can't hear you. Then I would request Dr. Ashok Kumar sir to please do the honors.
Our next is Dr. Archana Verma, and I think Dr. Archana Verma again in this forum and with AMOX doesn't need any introduction. She is the vice president.
Even I can't hear Dr. Ashok nicely.
Hello, I am audible now?
Yes.
Now you are.
Yes. So I think what I will repeat it, whatever I said, so that Dr. Archana Verma can also hear it. I was saying that Dr. Archana Verma is our next speaker, and we don't. She doesn't need any introduction. I think we all know, and Amox also is well aware about her. She is the vice president of Foxy currently, and otherwise she is from UP, and she was the founder president of West UP ISOPAB chapter and advisor of UP Call, and she has lot of work in the Foxy for last so many years, and she is a prominent leader of Foxy. So may I invite Dr. Archana Verma, madam, please.
Yes. Thank you. Thank you, Dr. Ashok sir. It's a nice today's day to see you and meet you and get introduced by you. And very nicely you said about that. In the meantime, I should share my screen also. हेल्प चाहिए होती है थोड़ा सा. It's very rightly said about any that herbal medicine. We need to be a little cautious.
Am I audible now? Am I audible now?
You are audible and visible now. Perfect.
Okay, visible. I was initially also. Yeah.
Good afternoon, Dr. Ranjana madam.
Yeah, good afternoon. Good afternoon to everyone. Dr. Pratik, Dr. Ashok, Dr. Rajen Singh, and Varsha. Hi.
Hello. So I should start my. I've already been
please
introduced
do.
as Dr. Ashok sir, and so I will just. I have to talk about the adolescent endometriosis, and we all know what the endometriosis is actually. It's a disease, of course, of the reproductive age, and there is a presence of endometrial-like tissues outside the uterus, which induces a chronic inflammatory reactions. And it's good to always suspect to avoid delay in optimum management and diagnosis regarding the this endometriosis. Now, this disease is actually really enigmatic. There's so many dilemmas in diagnosis, and it's a debilitating disease and progressive, and as such, no definitive cure. We can restrict it. And a little overview of endometriosis is we know that it's a lesion of causes a little, not little, but rather chronic and sometimes too much of the pelvic pain and infertility, though in adolescent infertility is not a concern, and it affects an almost totally of 176 million women of reproductive age. And they, when they were taken history, they had this dysmenorrhea, and they were not diagnosed as such of not even thought for the endometriosis. And regarding the cause of endometriosis, it's generally uncertain, but it's likely to be multifactorial, including the genetic factors and possibly in epigenetic influences, and perhaps promoted through environmental exposure. And so finally, endometriosis is taken as a proliferative estrogen-dependent disorder. And am I audible now? So, and regarding the endometriosis pathogenesis, the retrograde menstruation is the most accepted theory, and these are the common locations of lesion which determines the type of a pain, the cyclical and the non-cyclical. Because of so many issues and dilemmas, many guidelines were formed, and one of them is the national and the international. And this European Society of Human Reproduction and Embryology is well taken sometimes generally for all the references of medical management and treatment and surgical treatment. And another very important by the Foxy only, it was a GCPR on the endometriosis, and it was made during, I think, in 2016. And another is very commonly used is the NICE guidelines from the National Institute of Health and Care. The incidences, actually the exact incidence of adolescent is not known, but the best estimates are that around 10% of the general female population. And this endometriosis registry reports that 38% of the women with endometriosis, they had symptoms at 15 years of age. This American Society of Reproduction Medicine is very well stated how to manage this endometriosis, and they say it says that to maximize the use of medical treatment and avoid repeated surgical procedures because it is not good to operate again and again. And the most common clinical presentation is a pain, because in pain can be both the cyclical, non-cyclical, and usually disruptive, affecting all sort of activities. It was generally found that 43% interfered with work and even difficulty in walking. And the emotional health also affected, and pain controlled their life of the patients and their mood changes. And they were found to be struggling with pain and being childless also, especially even when they were counseled and they know it may affect their fertility, they felt depressed also. So we have to take care of all this, and this common pain, they should be taken care of at any age. And the presumptive diagnosis is generally made because generally there is a delay in diagnosis, and it's mainly clinical. When there is a severe primary dysmenorrhea and frequently resistant to OCPs and all the non-steroidal anti-inflammatory drugs, we must think for the endometriosis. And mainly 5 factors are there to diagnose. We can see the history, a good history, and a clinical examination, imaging studies, biomarkers, and response to therapy. Among them, let's see how many of them are very useful. We have seen that a history is quite important, and clinical examination. Sometimes there is not no sign, or only symptom is a pain, and sometimes there is not even a pain. So how to treat them? So generally, whenever there is a pain, and if we take it as a endometriosis, and the main treatment is the medical, giving analgesics, oral contraceptives, Dynogest and progestogen and GnRH analogs, and surgery, though is not a favorite one, but sometimes diagnostic laparoscopy is done when there is no no treatment, there is a treatment failure, medical treatment failure, then we go for the surgery. And this algorithm for imaging diagnosis is depending on the availability and affordability. The ultrasound, pelvic ultrasound, or transvaginal ultrasound, or transrectal ultrasound, and MRI, and laparoscopy, and biopsy. Generally, in reproductive age group, the laparoscopy and biopsy is the gold standard, but not in the adolescent type. And sometimes even the ultrasound is also not very helpful. And regarding the role of MRI in diagnosis of adolescent endometriosis, is sometimes we always think that MRI is very, very helpful and very, very diagnostic. But we should be aware that all the clinical lesions, peritoneal lesions, they cannot be detected by the MRI. And MRI can detect lesion of more than 1 centimeter, and it is mainly helpful in rectovaginal endometriosis and deep-seated disseminated endometriosis in more than 90% of the cases where we are suspecting the bowel and the bladder involvement. So MRI is not a first choice. And this role of biomarker, once again, that CA125, especially in whenever there is a chocolate cyst, we go for it, but it should not be used to diagnose endometriosis in isolation. Though there are reports that CA125 is increased, and there are so many more sophisticated lab markers are also available, and there's a panel consisting of this CA125, chemokine receptor, CCR type 1, mRNA, and monocyte chemo attractant protein MCP1 shows 92% sensitivity and 82% of specificity, but they are found to be very a little costly and not so useful, or not used. So these are few of the stories, and sometimes asked in the panel questions. So I have shared here also. there's one patient of 18 years, unmarried. She came to the OPD with progressive dysmenorrhea and periodic bloating, diarrhea, constipation for 2-3 years. General examination was normal. And as per ASHRAE 2010 guidelines, immunological biomarkers were not done. And mainly counseling was done of the girl and her parents. And they suspected that we were suspecting endometriosis and how to plan for future. They were thinking that because the patient is girl is so much in pain, they must you must operate, and because there may be some there must be some problem inside. However, this empirical treatment was given for 60 days and the pain was relieved, and it confirmed the diagnosis. Again, another one is also 17 years old, right-sided endometrioma, 4.5 centimeter. And here also thinking that the surgery should be avoided except in severe pain. Counseling was done. Risk of ovarian damage was also explained to them, and Dynogest was given to 12 weeks and it receded, and there was a drastic improvement. And this girl is our champion for the endometriosis, and because they were very happy that without operation she was feeling normal and there's no tumor inside. And another is a patient, she came into emergency acute pain, and it was a 10 centimeter chocolate cyst, and it was operated and later on put her on Dynogest, and she also recovered very well. So in management, the counseling is quite an important step here, because if we tell them that the endometriosis is a chronic disease and it's not going to go within 15, 12 weeks or 10 weeks treatment, it's almost they have to plan for even after all the reproductive years throughout till menopause, and it definitely requires holistic multimodality care over the entire reproductive age span. And this we have to explain to them very well. And end goal should be kept in mind. Number one, that fertility is to be taken care, and relief from the pain and the compressive effects is also needed. And the thirdly is very importantly is to slow the disease progression. So unless and until we counsel our patient about the pain and the pain management, they won't feel good. And this apart from medicines, this yoga, lifestyle changes also helps. And this is a very smart algorithm for management. It was given to me by none other than Dr. Pratik Tambe. And so it shows that when to start, what to see, and especially how much treatment can be given and for how long. This is a very nice chart, and we should keep it in our OPD, and we can just look after it. And then this regarding medical management, because the girls, if you give OCPs, they feel very shy and they think that something is wrong, and they are not so willing. This Dynogest is a recent entry for the treatment of endometriosis, and in a dose of 2 milligram daily for 12 weeks, it's significantly very, very effective than the placebo or other drugs for reducing endometriosis associated pain. And sometimes one very special patient, she was almost visited 10 or 15 doctors, including gynecologist, surgeon, and physician. And when she came, we just tried Dynogest, and it is a miracle drug, I call it, and her pain was gone in no time. And this, when you are suspecting endometriosis, the endometriosis should be considered in patient with persistent, clinically significant dysmenorrhea, and despite treatment with hormonal agents and NSAIDs, particularly if no other etiology for chronic pelvic pain or secondary dysmenorrhea has been identified based on history and physical examination and pelvic ultrasonography, then always think of the this endometriosis, and especially family history of endometriosis increase the risk of endometriosis 7 to 10 folds. And this suspected endometriosis, again, the benefits of here, when we think of for the laparoscopy, it's actually the benefits are only for the confirmation of presence or absence of the endometriosis or other causes of the chronic pain. And sometimes when the patient is not responding to the medical treatment, And it's also sometimes present an opportunity to treat by the coagulation, ablation, and resection of the visible implants and adhesive disease with lysis of adhesion. So after we can for surgery especially, the shared decision making with the patient and their family should be done, and among the obstetrician and gynecologist, and we must opt for the medical treatment for mainly, and we should not even feel shy to consult other gynecologists or even sometimes the surgeons also. Then the role of the surgery is somehow quite limited in this, in especially adolescents, and because the appearance of the endometriosis as such, because once you are doing the diagnostic lab, it's the appearances inside is quite different than the adult one. And in adolescent, endometriotic lesions are typically clear or red and can be difficult to identify, especially when we are not very much familiar, and they are very red spots, and we were thinking of that black chocolate cyst type of a thing, so that it can be missed on diagnosis. And biopsy of the suspicion lesion sometimes also may not confirm the diagnosis. So biopsy is again here not something very good. And at laparoscopy, most adolescents are diagnosed with early stage endometriosis. And when counseling family about surgical finding, it is important to communicate that the stage and location of the endometriosis is not directly related or with the severity of the symptoms. And the goal of therapy mainly includes symptom relief, suppression of disease progression, and protection of the future fertility. It's one, and the golden line is this only. And therapy must be individualized, and obstetrician and gynecologist should consider patient choice also, and need for contraception and contraindication to the hormone use. If there are any contraindication to the hormonal therapy, then we must discuss the adverse effects and counsel the adolescent and her family on the treatment options. And mainly it is conservative, we all know. And this so the full and final thing is the first line therapy for the adolescent with either surgically diagnosed or presumed endometriosis includes same hormonal suppression, and using a continuous combined hormonal contraception is quite very simply. And patient with endometriosis who have been refractory to conservative surgical therapy and suppressive hormonal therapy often benefits for at least 6 months of GnRH agonist therapy also with ADVAC hormone. And limited data exists regarding the long-term effects of GnRH agonist therapy on bone mineralization in adolescent patient, because GnRH we generally avoid giving to the adolescent because of this bone marrow, this depression and demineralization. And the patient treated with GnRH agonist should begin ADVAC therapy at initiation of the treatment. So sometimes this dual X-ray absorptiometries at scanning at the beginning is not advisable, and it is seen that even at the 1 year or 6 months, it has not created much problem. And so the take-home message very, very clearly is that obstetrician gynecologist should counsel patient and quite dietary good dietary intake about the calcium, vitamin D, and benefits of weight bearing exercise during GnRH agonist therapy. And after leupride is discontinued, patient should begin continuous hormone suppression therapy. And although CA125 levels may be increased in patient with endometriosis, this ACOG does not endorse using CA125 to monitor treatment or screen for endometriosis. And a non-steroidal anti-inflammatory drug should be the mainstay of the pain relief for the adolescent with endometriosis. And they should be told, generally in their mind, it is that if we take painkillers, our fertility will be gone. So we have to just take care of this. So it's an ever-evolving field with new updated evidence frequently associated with impaired ovarian reserve and poor oocyte quality, especially if we are going to operate. So any surgery, therefore, compounds the issue even in the best of the hands, and we should not go quickly for the sake of doing operations or learning laparoscopy, and this medical management long term yields good result, and we should rely and good counseling also. A doctor should inside, that means not only the patient, doctors also need to be counseled, and they need to be aware that they should rely somehow majority of the cases on medical treatment only. Thank you very much for patient hearing. And we have Dr. Pratik Tambe, the expert, and Dr. Ranjana Khanna, Dr. Rajit Pradesi, sir.
Actually, that was a wonderful talk, Archana. And but I just wanted to point out two things. One is that the most problem that we are facing is when an adolescent comes with endometriomas, because the chocolates they are very troublesome to treat, because we try medical, but medical treatment normally does not work. So normally what happens is, if the cyst is very big, more than 4 centimeters and causing acute pain, then we are left
that
with...
I have discussed, that I have already told, yes, that if the cyst is big and the patient is in acute pain, we need to go for surgery, of course, and with add-back hormone therapy.
But what we must do is that the surgeon should be really qualified to do this and damage as less of ovarian tissue as possible. And another thing is that
madam, everybody who is operating, they think best, they are the best. So that's why I thought it's an awareness and counseling of the doctor also. Once
very
operated,
important. And AMH levels,
patient should not go somewhere else and hami ko kar lein aur hami iske paas rakh lein. So हमें थोड़ा सा अपने आप को थोड़ा सा अलग रखना पड़ेगा.
AMH levels have to be checked. AMH levels have to be checked. And what is more important, that we should take a bit of the tissue maybe for autografting, or the ova can be freezed for further fertility, for future fertility, because we all know that it is a highly invasive disorder and it keeps on destroying all the tissue.
Dr. Pratik talks on this lines very nicely along with Dr. Nandita Palshetkar. I have heard him and Dr. Nandita. It was really very, very good, I think. Dr.
And
Pratik
now there is, I was reading somewhere that there is this thing that girls who are doing night shifts, like in call centers and all, they are the ones who are very likely to be affected by endometriosis later on, because it changes the circadian estrogen release in their bodies. So these girls who are doing night shifts and not sleeping at nights, their hormonal status gets altered and they can be predisposed to endometriosis. And secondly, the newborn infants, the girls who bleed per vaginum, are the ones it has been seen who later on develop endometriosis.
Yes, that is also infant. That is also been
and then another
observed.
thing that they are saying nowadays, that some green tea and all has also a beneficial role in endometriosis. How far it is correct, we don't know, but we can always advise that yes.
Yes, madam. Yes,
that is healthy. I'm sure about healthy diet, Pratik could tell a lot.
Yes, Dr. Ranjana. Yeah, I think we have to tell each and every gynae, ladies especially, I must say, to take care of their reproductive issues, because all these exercises are getting less, and they are the way they work, and it is going to affect.
Good afternoon,
lifestyle modification, holistic care.
Initially, hi.
Dr. Pratik is the best person to talk about endometriosis. Give the take-home message, Dr. Pratik.
So it's a fantastic talk by our first two speakers, Dr. Varsha Lade and Dr. Archana Verma. Thank you so much for the wonderful discussion, Dr. Pardeshi sir, Dr. Ashok Kumar, and Archana Khanna. I think we have Dr. Priyankur Roy with us. He was held up in the VIP patient. I hope he can join us for his talk, which is on parent reserve testing. Yes, I see him with us. Can we have his CV please up on the screen? I would request Dr. Nagarkar sir please do the honors and introduce our final speaker of the day, Dr. Priyankur.
Yeah, and a final.
Thank you, Pratik. At the outset, I wish to thank Dr. Pratik Tambe for inviting me to this webinar. He has always been so active and having webinars regularly, and it's my privilege to have him as a dear friend, that he is always there for all of us. It's also my honor to introduce another young dynamic friend from our east of India, and that is none other than Dr. Priyankur Roy. He's just celebrated his birthday, so if I may just wish you happy birthday, dear Priyankur. Wish you all the best in all your future endeavors. So going ahead, Dr. Priyankur is a consultant infertility and gynae endoscopy specialist at the Noah IVF and Roy's Clinic at he's India represented at the WATOG for 2018 to 21. He's the national coordinator of the perinatology committee of Foxy. Sorry, I said Siliguri because the pictures were coming in the way. He's the national coordinator, perinatology committee of Foxy. He's the East Zone coordinator for the infertility and endocrinology committee of Foxy. He's the joint secretary of the Siliguri OBGYN Society, organizing secretary for the East Zone Yuva Foxy of 2020, which was so very successfully organized. He's published more than 60 articles in international and national journals, authored more than 50 chapters, and in peer-reviewed journals. He's presented more than 50 articles in various conferences. So the talk, he's going to be speaking on ovarian reserve tests. So over to you, Dr. Priyankur.
Just to add his biodata, I saw flyer. He's contesting for public awareness committee. So we wish success in his future endeavor in Foxy. And public awareness committee is by heart by Dr. Archana Verma. And it's quite in demand, public awareness committee.
He has made it, he has made it aware to everyone.
Yes, yes.
But it was Dr. Rajendra Pradeshi who really said this committee is quite okay for you, Archana. Go for it. And Dr. Pratik, I forgot, and very sorry. My gratitude to President Dr. Nandita Palshetkar and Dr. Arun Naik.
Thank you, ma'am. We will convey that.
Thank you, Rajendra sir, for the introduction. I would like to thank Dr. Pratik Tambe sir for giving me this opportunity to be with all of you today. And thanks to Nandita ma'am and also Dr. Arun Naik sir for conducting this program. It was a wonderful talks that were given by Dr. Varshala Ade ma'am and Dr. Archana ma'am. And thank you so much for that. And thank you, Rajendra sir, for the wishes that you have just put forward. Thank you so much. So I have been, and I'm really sorry for shifting my talk from the first talk to the last talk. I got stuck with a patient actually. So I will be speaking to all of you today on ovarian reserve tests and its clinical correlation. So natural fertility, we all know this is a common graph that we see. This is a common graph that we see in most of our presentations and our textbooks related to infertility. That is, with increasing age, we know that the natural fertility decreases, the optimal fertility decreases, there's a decline in fertility and end of fertility, which leads to menopause finally. So the reproductive aging, if you look at, it's a biphasic decline. Loss of follicles accelerates around 37 years and precedes menopause by 10 to 12 years. So fertility reduces with increasing age of women because of reduction in the number of primordial follicles. A study by Abma et al. In 1997 stated that the chance of not conceiving a first child within 1 year I'm really sorry for that. Yeah. So not conceiving a first child within 1 year increases from under 5% in women in their early 20s to approximately 30% or over in the age group of 35 years and older. Although the majority of women of older age will obtain the desired pregnancy within 1 year period, the chance of becoming subfertile increases 6-fold times in comparison with younger women. So poor ovarian reserve is basically low ovarian reserve is a consequence of follicular depletion and follicular dysfunction. Follicular depletion is due to the initial low follicular stock and accelerated follicular atresia, and follicular dysfunction will result from deficient receptors or inadequate bioactive FSH. If you look at the age of the woman is a simple way of obtaining information on the extent of her ovarian reserve in terms of both quantity as well as quality. However, in the view of substantial variation in the decline of the reproductive capacity with age, as stated in 2002 by Pearson, there is a need to identify women of relatively young age with clearly diminished reserve, as well as women around mean age at which the fertility on an average is lost, that is approximately 41 years of age. So in clinical terms, if you look at, the aim is to identify women with high risk of producing poor quality eggs and or very low probability of becoming pregnant, as well as those who produce enough oocytes to have a good chance of becoming pregnant even if female age is advanced. If it appears possible to identify such categories of women, then management could be individualized, for instance, by stimulation dose or treatment scheme adjustments. Concerns with infertility treatment. Poor ovarian responses can happen and can lead to cycle cancellations. Poor pregnancy rates and excessive ovarian responses, which we do not want, can lead to ovarian hyperstimulation syndrome, as well as high E2, which is detrimental to the outcome of the treatment protocol. Ovarian reserve is thus defined as the number of quality of follicles left in the ovary at any given time. An accurate measure of quantitative ovarian reserve would involve the counting of all follicles present in both ovaries, as is done in postmortem studies. For obvious reasons, in ovarian reserve testing, the true size of the follicle pool has not been used as the benchmark of evaluation, as shown in studies in 1997, 2004, and also by Scott, which is a very famous study, which was again published in 2004. Ovarian reserve can be considered normal in conditions where stimulation with exogenous gonadotrophins result in development of at least 8 to 10 follicles and retrieval of a corresponding number of healthy oocytes at follicle puncture. Over the past 2 decades, a number of ovarian tests have been studied for their ability to predict outcome of IVF in terms of oocyte yield as well as occurrence of pregnancy. Some of these tests have become part of the routine diagnostic procedure for subfertile couples who will undergo various modalities of treatment. So what are the tests that we routinely look at for ovarian reserve? Hormone analysis, ultrasound techniques, as well as a few dynamic testing. But we all know that hormone analysis as well as ultrasound markers are our mainstay in treatment. So ultrasound markers are ovarian volume, which is used but not much. Antral follicular count is the one which is the most important and used most commonly for detection of the ovarian reserve test, and ovarian stromal vascularity can also be looked at. If you look at the hormonal markers, it could be anti-Mullerian hormone, which is the most commonly used hormone. It could be FSH, inhibin, and estradiol as well. But of course, for our clinical use, it's antral follicular count at AMH, which is the primary testing modality for these patients. Some dynamic tests like clomiphene citrate test and GAST are not used clinically anymore. So just to brief about all the tests that can be done, follicular stimulating hormone usually measured on day 2 or day 3 of the cycles. Women with more than 10 are poor responders to ART, and women aged more than 30 with one value of FSH more than 14 can give a worse result in case of IVF treatment as well, and it's better to counsel them for a donor cycle treatment. Serum estradiol can also be done. E2 alone of little value to assess the ovarian reserve. If combined with FSH, then better than only E2. High baseline E2 with normal FSH is not predictive of correct ovarian reserve because high baseline E2 may mask abnormal FSH levels. E2 more than 80 picogram per ml on day 3 of cycles, higher chances of poor results. So it's very important for us to know when we should not, like even after counseling, when we should not go ahead with the IVF treatment, or at least counsel them that telling that the results may be very, very poor. We can also look at inhibin B, heterodimeric protein similar to AMH. Level of more than 45 picogram per ml is basically significant of a poor response to medications for inductions. It's not widely used anymore. Clomiphene citrate test that I was mentioning, Baseline FSH, LH, and E2 followed by clomiphene citrate 100 milligram per day from day 5 to day 9 can be given. Measure the E2, FSH, and LH on day 9 to day 11. Exaggerated FSH after CC is bad prognostic test. Inference not better than basal value and of no use, no much use nowadays. I'm not very sure if people do it nowadays much. So now coming to the most important predictor that we look at, that is the anti-Mullerian hormone or the AMH. Relation of AMH with other biochemical predictors. Of course, AMH assesses the primary, the shift from the primary to the secondary to the small antral follicle, and that is why it is the most predictive value rather than the prediction of the inhibin B, estradiol, and FSH, which is more of because of the dominant follicles, and that time the recruitment is more or less there already. So AMH is a glycoprotein originally known as Mullerian inhibiting substance, appears in females at puberty, produced by granulosa cells of preantral and small antral follicles, and AMH is not expressed in the atretic follicles or in the theca cells. Maximal expression occurs in the preantral and small antral follicles. Expression disappears in maturity pre-ovulatory follicles. Expression restricted to the granulosa cells of the cumulus as well. Possible actions of AMH in the ovary, if you look at, it is because of the inhibition of the follicle activation and growth, inhibition of FSH stimulated growth, inhibition of GH growth, and inhibition of aromatase as well. So it's mainly the primordial to the preantral follicle which gives us the levels of the AMH. So this is a curve, we all know it, with increasing age the AMH levels also fall, but there is no variation of the AMH in any time of the cycle. So it's not necessary, as most of the hormonal tests we do at day 3, day 2 to day 3. It's not necessary to do it over there. You can do it at any point of time, at any point of the cycle, because the results are pretty much valid and pretty much, so it doesn't vary much. So AMH in ovarian reserve, a number of studies have been done. Serum AMH shows a progressive decrease with age and correlate well with AFC, as I've already mentioned. AMH is the only marker of ovarian reserve showing a mean longitudinal decline over time in younger women and in women over 40 years. AMH reflects the continuous decline of oocyte or the follicle pool in relation to the age. So how do you do the testing? It's mainly the initial kit that had come from the Beckman, Coulter, and it's the AMH Gen to ELISA test. Serum plasma is taken, 20 microliter is required, and the calibration range is usually 0.16 to 22.5, but it can differ a little bit from lab to lab. But always remember that we need to note the unit. The most common used unit is nanogram per ml, but there could be other units as well, and we should not get confused with the other unit and thinking that the levels are normal. There is no cross reaction with inhibin A, activin A, FSH, and LH. So that is why AMH results are more or less very significant. So if you look at the nanogram per ml levels, high is more or less 6.8. And if you look at very low, 0.3, below which I think trying for a self IVF cycle is something which is a little difficult to produce a result. The significance of AMH, of course, with increasing age means decreasing AMH levels. Lower AMH levels at any given time, irrespective of age, predicts a poor response to treatment, and high AMH levels, candidates are prone for OHSS. That is why with the high AMH level, in case of, when you see a high AMH level in case of PCOS, we are not happy because we know that there can be OHSS, and then we of course plan for antagonist cycle, maybe with the agonist trigger to prevent OHSS. So AMH can be related to most of the things that you see in a female, right from IVF success to family planning to PCOS to menopause to everything can be sort of predicted by the AMH levels. Then coming to the radiological diagnosis of the ovarian volume. This was initially done, and there were studies in 95 and 97 by Sirop et al. And Lass et al. Who stated total ovarian volume and volume of the smallest ovary predictive of the peak E2 levels, number of oocytes, and cycle cancellation. Mean ovarian volume prior to stimulation predictive of the poor ovarian response. You can see over here the ultrasound beautifully shown the whole ovary in the same picture, the same cut showing the whole ovary, and we have to take a cross-sectional or a dimensional measurements to get the ovarian volume. Now, antral follicular count, we all mostly rely on this. This was based on the study which was first published in 2000 by NG et al., who has done a lot of work in this ovarian reserve test. And he stated that count of total follicles measuring 2 to 9 mm in both ovaries on day 2 to day 3 of cycles is normal, can be done on any day of the cycle, more accurate count when measured through the transvaginal ultrasound, and AFC achieved the best predictive value of the number of oocytes obtained, followed by the basal FSH is what he had said. But of course, FSH on day 2 and day 3 is where we need to do it. But we had know, and we have come to the predictive thing now, that AFC along with AMH is probably the best predictive value that we can think of. So these are the two studies that were once published by Jayaprakashan et al. In 2008, who stated ultrasonographic assessment of the total number of antral follicles measuring 2 to 9 mm is a reliable determinant of ovarian reserve. The total antral follicle count is made by counting the follicles measuring 2 to 9 mm in both the ovaries. Another study in 1989 stated that at any given point during menstrual cycle, the ovaries contain follicles at different developmental stage, and antral follicle count must be made during the early follicular phase. So antral follicular count, of course, counting the number of follicles, like we can see in the ultrasound picture over here. Maybe on the ovaries, we can see 2 to 3 follicles over here, and that's how we should count. We should count the entire ovary. I mean, from one plane to the other, all the planes we should check, and we should go from one end of the ovary to the other end and check for the number of follicles that we can see when we are counting the antral follicle count. So how is it significant? 2-dimensional or 3-dimensional ultrasound. Of course, 3-dimensional is better, but we need to consider the cost factor as well as the factor of expertise that is required with the 3-dimensional ultrasound. 3D image displays and rendering techniques do not appear to offer any advantage over the conventional 2D display in terms of AFC measurement reliability, as published by Jayaprakashan et al. So we can very reliably go ahead with our 2D scan and we can get our antral follicular count. So antral follicular count, normal AFC count, if you see 10 to 18, poor responder less than 10, hyper responder more than 20. But make sure that when you're counting the ones between 2 to 9 mm, that is more important. This is a new thing that has come up. That is called the SONOVAC. That is sonography-based automated volume count. Automatically calculates the number of volume of hypoechoic structures in the volume dataset, can significantly reduce time for assessment and reporting. From the calculated volume, and average diameter can be calculated. It also lists the objects according to their size. It's the most cost-effective single test, but we need to definitely remember that when we are doing this, it definitely needs sort of a 3D higher end machine, basically, because a 3D calibration of the thing is required for assessing the sonography. AFC versus the ovarian volume, if you look at the predictive performance of ovarian volume toward poor response is clearly inferior compared with that of AFC. AFC may be considered the test of choice when estimating quantitative ovarian reserve before counseling regarding natural fertility or treatment, published by Hendricks et al. In 2007. AFC versus FSH, again, the predictive performance of AFC towards poor response is significantly better. AFC might be considered to be the first test of choice in the assessment of ovarian reserve prior to counseling regarding to natural fertility and treatment. I'm very sure most of us do this because AMH is good, but it's costly, and sometimes it's not. I mean, like it's becomes a little difficult to sometimes, to repeat it maybe. So basically, one baseline AMH and followed by AFC counseling, AFC testing and counseling is the mainstay that stays for most of us in the field of fertility. So AFC versus hormonal markers, AMH, if you look at AFC, the result, of course, immediately available. Moderate inter-observer variability is there. Moderate intercycle variability is also there, but good correlation with oocyte number can be seen. In AMH, result is not immediately available. No inter-observer variability, less intercycle variability, and good correlation with oocyte number can be seen. Now coming to the last test, the ovarian stromal vascularity. Adequate vascular supply to provide endocrine and paracrine signals may play a role in the regulation of the follicular growth. Normal responders had higher peak systolic velocity of ovarian stromal vessels than poor responders. Women with RI of more than 0.56 had longer stimulation duration during IVF cycle and lower oocyte number. So basically what we need to look at is the resistance has to be a little on the lesser side. The blood flow to the ovary has to be good. And of course, that will give us good yield and we will get good quality follicles. So if you look at the ovarian stromal vascularity by Doppler study, mean RI was positively correlated with the AFC. No difference in ovarian response between those with unilateral or bilateral absent ovarian stromal flow and bilateral ovarian stromal flow. Ovarian stromal vascularity indices by 2D Doppler had no predictive value for ovarian response. So this is the vascular study that you look at. On the left-hand side, you can see that the ovarian volume is measured, and the vascularity, you can see there's a good vascularity over here, which could signify a good number of yield and a good response from this ovary. So we look at the predictors of ovarian response. So of course, we have talked about all of them: number of the antral follicle or the AFC, AMH levels, other hormonal levels like FSH, LH, stromal blood flow, and total ovarian volume are the things that we usually look at. Now, if you look at the 3D ultrasound, of course, it has got advantages. That is, accurately measures the volume measurement, follicular volume, endometrial volume, detection of the uterine abnormalities, evaluation of the fallopian tubes to look for hydrosalpinx. Now, out of this three, the people who fertility people who routinely do ultrasounds know it. The detection of the uterine abnormalities is the only thing in this out of these three factors, which is the go-to factor for a 3D ultrasound. The others is as good. We can do it with a 2D ultrasound itself and does not need a 3D ultrasound. So uterine abnormalities, though a 3D ultrasound or a hysteroscopy is basically similar, and even 3D ultrasound gives us good results when in compared to a hysteroscopy. Probably with the hysteroscopy, we can do the corrective procedure as well, but for diagnosis, a 3D ultrasound is good enough. So impact of obesity or insulin resistance on ovarian responders. Both insulin resistance and obesity have adverse impact either alone or in combination, may lead to either explosive or poor ovarian response, very unpredictable. Weight reduction plus minus insulin sensitizers are essential for optimal ovarian response and good fertility outcome. So I would like to conclude this talk by saying an ideal marker should have the potential to predict both qualitative and quantitative response to ovarian stimulation. Currently, this is not available. Hence, use of one marker is clearly justified. And so, of course, it's up to us to decide whether we want to depend on AMH and AFC, or I think for a low resource setting, AFC is as good as a detector as it can be, and if possible, if it's feasible, then of course AMH can be added on, and that will give us a extra additive or extra predictive value. Thank you so much for the patient hearing, and I hope I finished in time. Thank you so much for the opportunity once again.
Thank you, Dr. Priyankur, for this wonderful talk. You have covered all the aspects of ovarian reserve tests. And I think in summary, I would say that, as you rightly said, AFC along with AMH, and I would just add one more A over there, and that is age. Age, the AFC and the AMH are the three A's which are normally very useful in predicting the ovarian reserve. And although there are many other tests like the FSH and the inhibin and all that, they are not so much in use. So, and then you have also elaborated on the newer test, that is the three-dimensional ovarian volume, the Sono AVC, which is a new upcoming test. But again, as you very rightly said, the man behind the machine is important. So just having a 3D machine is not enough. You should be having an expertise in 3D ultrasonography, where you can identify not only the ovarian volume, but also the other aspects like the endometrial blood flow, the endometrial RI, etc., which will help us in, and also the stromal blood flow of the ovary. That is also something which is a new concept which you have brought out. So thank you very much for this wonderful insight. And as you again said, for low research settings, it is the simple two-dimensional antral follicle count, which is still the gold standard. And I think we should all swear by it, because that will tell us a lot. And I think it's always prudent for all infertility specialists to do a day 2 or a day 3 sonography, which tells you a lot when you proceed with the cycle. So thank you very much once again. And back to you, Dr. Pratik, for taking it forward.
Thank you, sir.
Ranjana Khanna ma'am, anything further you would like to add?
Yeah, I just wanted to say that actually in our practice, normally we are relying most heavily on, of course, age to 40 years age group. So that makes us very wary to begin with. And then, of course, we do the EMH and then the antral follicle count. So we are basically, as Dr. Rajendra has very rightly said, we are basically relying on these. And I think you did a brilliant job of your presentation.
Thank you, ma'am.
We have over 500 viewers who are logged in today's event, and there are several congratulatory messages for all the speakers, chairpersons, the excellent scientific menu that is there on display, and there are viewers who are logged in from actually the country, not just Maharashtra. And I will just take the time to read out few documents. One is she says excellent scientific content. There's one from Dr. Lakshmi Sen who says that this is wonderful and a lot of practice guidelines. There are some comments from the members from other parts of the country as well, congratulating us for this entire series. I think it just goes to show that thanks to the lockdown and pandemic, though Dr. Anjana Khanna is in Allahabad, it takes sometimes 8 or 9 hours for me to connect from Mumbai to Delhi and Delhi to Allahabad.
Yeah.
Within 5 minutes, I can be connected to her online. It is really amazing.
Really think, yeah, this is really miraculous this way. So I feel webinars are really very useful. Otherwise, programs, acha flight tickets, and then then going to the airport, and now it's just a click away and we are together. And we are gaining, I think, more information. Because to a conference, we were always distracted, acha, those people are having coffee, let's go out, chat. Now we are just focused.
We are waiting for Priyankur to...
You're always on camera, so you cannot...
Priyankur, a belated happy birthday to you.
In Siliguri, very soon. Once physical event starts.
Absolutely.
Dr. Ranjana is a person full of positivity. We can learn how to smile even in pandemic.
So I think we've had a very engaging and positive discussion on fantastic topics today: ovarian reserve test, medical management of fibroids, and adolescent endometriosis. As the convener for today's event, I would like to place.
कुछ पता नहीं अभी साथ में आ जाए सीएम साहब का ऑर्डर भी आप लोग एक आयुर्वेदिक की दवाई भी
The faculty. Our president of AMOS, Dr. Nandita Palchetkar, secretary Dr. Arun Nayak, ICOG chairperson Dr. Vedhana, secretary of ICOG Dr. Ashok Kumar, who is here as a chairperson. Our vice president of AMOS, Dr. Rajendra Singh Pardeshi, my dear friend Dr. Rajendra Nagarpatti, thank you so much for being with us throughout the event. Dr. Anjana Khanna, our past vice president of FOXI, all the way from Allahabad. It's lovely to see her in person. And 3 amazing speakers, Dr. Priyankur Roy, Dr. Varsha Dhade, and Dr. Arjuna Verma. Thank you so much for being with us. I'd like to express my gratitude to the ICOG chairperson and secretary for the ICOG credit point, and to our academic partners for today, the Acumentis Viviana team, for being with us throughout this entire series of programs on key issues in obstetrics and gynecology. We have over 500 viewers who logged in into today's event, and if you refresh the audience portal, you will see that the download button has become active, so you can download your ICOG credit point certificate. We hope to see all of you very soon in the near future. Thank you so much. Take care.